Hello. In today's video, in this series on medical presentations and notes, I'm discussing discharge summaries. Keep in mind that I practice medicine in the United States. Documentation practices in other countries might differ from what I discuss here today. Of the core medical documents that hospital-based physicians write in the chart, none have as much variability between institutions as discharge summaries. They simply aren't standardized to the same extent as H&Ps and progress notes. This brings me to some huge caveats about this video. What I'm presenting here is the closest I've come to something with which I think the most people will agree, but that's not going to be everyone. If you're a trainee and your residency program or supervising attending insists on you using a different format than what's presented here, if so, it is what it is. Also, U.S. hospitals typically have institution-specific requirements about the content of a DC summary, and these requirements are often not for the direct benefit of clinicians or patients, but are to track quality metrics and to optimize billing and coding. If your specific hospital has such clinically meaningless boilerplate language or other auto-populated data, don't unilaterally remove it unless you are prepared to incur the wrath of the billing and coding department. With that out of the way, what exactly is a discharge summary? It's a document in the electronic medical record that summarizes a patient's hospitalization and outlines the next steps following discharge. It is the most important document that's produced during a hospitalization, but ironically, most discharge summaries are not very good. Now, there are a lot of reasons for this. First, as mentioned, they aren't standardized. Second, they are often not formally taught to trainees in the way that H&Ps and progress notes are. There is an incompleteness in the passing of information from one clinician to the next during the hospitalization. The longer a patient has been hospitalized, the more likely it is that they have gone through at least one transfer in care between physicians or teams, such that the person who ultimately discharges them is not the same person who initially admitted them. When there's a transfer of care, no matter how good the sign-out seems to be in the moment, there will always be information lost. There is insufficient time allotted to writing thoughtful summaries. And last, and I think this is the biggest reason DC summaries are sometimes terrible, they are trying to achieve too many simultaneous goals. What are those diverse goals? Well, DC summaries are meant to communicate information to other clinicians. That includes the patient's primary care provider, outpatient specialists, the clinical team at a skilled nursing facility or another hospital if the patient is being transferred, and future ER and admitting teams for the patient's next hospitalization. For each of those groups, there will be a different set of information that will be helpful. DC summaries are also used for non-clinician documentation, which I mentioned earlier and specifically refers to coding and billing and tracking quality metrics. Lastly, as with every other part of the patient's chart, the DC summary is a legal document and can be entered as evidence in legal proceedings. This isn't a huge consideration for the most part, since the vast majority of what's contained in the DC summary should have been included in previous notes. But this may be the only document that clearly outlines the follow-up plan after discharge, as well as the only document that describes the circumstances when a patient leaves against medical advice. In addition to these overt, easily identifiable goals of a DC summary, there is a less obvious but underappreciated value to writing them. It gives the discharging clinician an opportunity to reflect on the hospitalization. What went well? What didn't? Was there a missed opportunity to arrive at a diagnosis sooner? Was there an iatrogenic complication that could have been avoided? And it provides a last chance to consider if the discharge plan and discharge medications make sense. The major downside to the anticipated future use of AI to write discharge summaries is that this step, a reflection on the hospitalization, will be lost, and that might not be worth the time saved. It is important to distinguish discharge summaries from a similarly named document, the discharge instructions. Similarities between DC summaries and DC instructions are that they both contain a primary diagnosis, the discharge medication list, and a list of follow-up appointments, but they are otherwise quite different. Summaries are primarily meant for communication with other medical professionals. Thus, they are written in medical language and are relatively long. They are required for all patient discharges and transfers, and in the US, they are required to be written within a few days following discharge. In contrast, instructions are for communicating with the patient or the patient's family. They are written in layperson-friendly language and are relatively short, though they should include a narrative as to what happened in the hospital, with a length and complexity dictated by the complexity of the hospitalization and by the patient's health literacy. Whenever possible, they should be written or accurately translated into the patient's preferred language, though unfortunately this is not always practical. DC instructions are not needed for patients going to SNFs or other acute hospitals. And for those patients going home, because this document may be the only thing they receive that provides their medication list and list of follow-up appointments, it must be completed and printed before the patient leaves the building. Now we get to the actual components and format of the DC summary. Although it is never explicitly written out this way, you can consider there as being three subdivisions in content: the big picture stuff, or the summary of the summary. Next, what actually happened to the patient in the hospital. And last, the discharge plan, that is, what is supposed to happen after the hospital. I'll run through each component one at a time, though we'll skip the obvious ones like admission and discharge dates, the discharging service, and the patient's primary care provider. The first section that requires any thought is the primary diagnosis. This is the diagnosis that best explains why the patient needed to be admitted to the hospital. Occasionally, a second or even third primary diagnosis might be appropriate if a complication occurred that substantially contributed to the hospital stay. It is perfectly fine and sometimes preferable to convey uncertainty in the primary diagnosis. Despite what someone from the billing and coding department might claim, if you are not sure of the diagnosis, don't imply certainty in your choice of words here. This is a common place for so-called chart lore to be introduced into a patient's medical record. For example, what do I mean by chart lore? Imagine a patient with a smoking history presenting with acute cough and shortness of breath. You treat them with prednisone and they get better, but they have no history of COPD. The chest x-ray was normal, and there are no pulmonary function tests on record. In that situation, even if you suspect COPD, do not write COPD exacerbation as the primary diagnosis, because once you do, that patient is now labeled as having COPD, and no one will ever explore the possibility that they actually might not have that and might have something different instead. So instead of COPD exacerbation, write suspected or possible COPD exacerbation, because that's going to be more accurate and will be less likely to lead to misdiagnosis. Secondary diagnoses include both in-hospital complications that are not severe enough to be considered a second primary diagnosis, as well as chronic but still active medical problems that predate the hospitalization. It seems like there should be separate sections for these two categories of diagnoses, but in current common practice, they often get lumped together. Let's take a look at a bunch of examples of well-composed primary and secondary diagnoses. We'll start with one that's very straightforward. Patient discharged from the internal medicine service with a primary diagnosis of left lower extremity cellulitis. Secondary diagnoses start with acute kidney injury secondary to dehydration, with the added clarification that this was resolved by the time of discharge. The fact it's listed here as a secondary diagnosis rather than as a primary diagnosis implies that it was mild, did not require any specific intervention beyond intravenous fluids, and did not significantly contribute to the hospital length of stay. Next is a patient discharged from cardiology with a non-ST elevation MI and acute heart failure with reduced ejection fraction. Secondary diagnoses are osteoporosis and major depressive disorder, which, unless further clarified, one would assume predated this particular admission. Here's a patient from general surgery. In this case, we have a primary diagnosis of septic shock secondary to bowel infarction. It would be equally fine to have listed septic shock and bowel infarction separately as two primary diagnoses, just as we could have said for the previous patient that the primary diagnosis was acute heart failure secondary to an NSTEMI. Now, let's switch to some examples with uncertainty. The primary diagnosis here, non-specific non-cardiac chest pain. This is a style preference of mine, but I think this terminology is usually preferable over atypical chest pain, which implies it might still be cardiac in origin, even if that's not usually intended by the writer. A much worse alternative is the diagnosis of, quote, rule out MI. The words rule out, often abbreviated R/O, should not be in a discharge diagnosis. Rule out MI is not a diagnosis. Here's a similar example, nonspecific viral syndrome in a patient with vascular dementia. If you don't know the specific pathogen, don't guess. In short, be as specific as possible, but no more specific than that. Occasionally, it may be helpful to suggest a diagnosis or general diagnostic category. Here's a patient who presented with fever of unknown origin and is being discharged with a fever of unknown origin, but with a suggestion that it is suspected to be from an autoimmune disease. Again, be as specific as possible, but no more so. And the last example here is a patient who was very sick at baseline with secondary diagnoses including metastatic lung cancer, whose primary diagnosis is given as failure to thrive with the diagnostic evaluation deferred due to transition to hospice care. Not every physician will love seeing a diagnosis that vague on the discharge summary, but if that's what you got, that's what you've got. Moving on, the reason for admission is nothing more than a summary of the HPI from the H&P. Although it is common to do this because it saves a few minutes, you should avoid copying and pasting the HPI verbatim, since it's typically longer than necessary for the summary. The hospital course is typically organized as a problem list, similar to H&Ps and progress notes, but focus on the big picture problems and big picture information only. If the patient was in the hospital for a month, no one is going to care what the creatinine was on day 5 or the fact that the patient got a mild transient headache on day 17. If, for some bizarre reason, that level of detail is necessary to review in the future, it's already been documented in the earlier progress notes. Despite it being a common practice, you should avoid copying and pasting the problem list from the day prior to discharge as the hospital's course. The goals of the daily progress notes and the discharge summary are different. For example, the order of problems in the hospital course should be prioritized based on how much it impacted the patient during the overall hospitalization as a whole, not just how important those problems were on the final day. The procedure section should include both surgeries and bedside procedures like paracenteses and lumbar punctures, including date and if there were any major complications. For discharges from surgical services, procedures are typically listed more prominently, just under the diagnoses or occasionally even above them. For key test results, only include those results that the outpatient clinicians are likely to care about. Do not copy and paste entire reports unless the patient is going to a SNF, the patient is transferring to another hospital, or a centrally relevant outpatient clinician will not have access to your hospital's EMR, but could be sent or provided the discharge summary more easily than a copy of the entire chart. But even then, only include those reports that are relevant to what those clinical teams are going to care about. For all the circumstances, very briefly summarize the results, like CT chest showed a spiculated 1.5 centimeter left upper lobe nodule without any lymphadenopathy. Short and to the point. Including the exam at discharge may be a billing requirement in some circumstances if there is not a separate progress note on the day of discharge. Even if not strictly required, it's still a good idea to include it. Focus on what is most likely to be relevant during a follow-up outpatient visit or during the next hospitalization. The functional status is often omitted or forgotten. This is a single line summarizing how independent the patient is at the time of discharge. For example, fully independent in ADLs, which stands for activities of daily living, able to walk short distances with a front wheel walker but requires one person assist for toileting and bathing, or non-ambulatory, non-verbal, requires total care. Now we move on to the discharge plan, starting with the discharge destination. This should be straightforward, but a common mistake here is to simply say something like discharge to SNF without indicating what specific SNF the patient is going to. The discharge medication list is almost always auto-populated by the EMR template, but you should read over it to ensure that it is consistent with the discharge med list that's going to be included in the discharge instructions that were given directly to the patient. Action items for the PCP include which outstanding tests they need to follow up, which symptoms should they be reassessing, and what side effects of new medications they should be asking about. These items should be written as a concise, bulleted list. Don't repeat long expositions of reasoning that are covered above in the hospital course. Some clinicians like putting the action items for the PCP right at the top of the discharge summary because they feel like the action items are less likely to be forgotten about. To me, this seems unnecessary, and it breaks up the format of having the entire discharge plan listed together in one section, but that's just a matter of personal preference. And last is the list of follow-up appointments and referrals, being as specific as possible, including which appointments have been scheduled and which are the patient's responsibility to schedule after they get home. I'm going to end with a list of some common mistakes in discharge summaries. Action items for the PCP are either absent or difficult to find because they aren't in a dedicated section of their own. Outpatient meds were changed without any explanation. The med list on the DC summary and DC instructions are not the same. The hospital course is too detailed. It includes entire copy and pasted radiology or pathology reports when not necessary. And last, it does not consider the note's most important audience, whether that happens to be the PCP, outpatient specialist, or SNF team.